Okay, thank you very much again, because this I had to speak at the last moment because the presenter for this talk could not make it for some unavoidable reason. Thank you very much again, Mangesh, for a request to stay back for this presentation. Thank you once again. So this time when I presented this last time, this was the James Parkinson's birthday. So I had put that picture of James Parkinson's birthday. Today is not his birthday. Tomorrow happens to be Teacher's Day. Now, when you look at neuropathy, I feel you should look at the Cinderella opinion or Cinderella complication. Means we never look at the feet of the patients of diabetes. We always look at the top, we examine the eyes, we examine the heart, we examine the blood pressure. The peripheral vessels and the nerves are hardly examined. And in fact, diabetic neuropathy is 107 amputations per week. This is the data presented in the Western studies. And of course, it's such a common complication, but it has never been looked in. And again, diabetic nephropathy and retinopathy is commonly diagnosed. That's why I put the picture upside down, calling it a Cinderella complication, because Cinderella has to lose her shoes and to become very popular. And that's how I say this is a Cinderella complication. This is Cinderella. So 50% complain of painful symptoms, and it goes to say that 50% of patients do not have painful symptoms. And this is the picture of the Ernest Bergman, who was performing the leg amputations long ago in Berlin, almost 125 years ago. And that was the treatment offered during those days. So lifetime incidence of diabetic foot ulcers is about 20%, 20 to 34%. 77% heal within 1 year, but 40% recur within 1 year. And 20% of moderate to severe diabetic foot ulcers require amputation. And what's scaring is the post-amputation, the mortality at 5 years, 70%, and at 2 years of end-stage kidney disease is of 74%. A kind of a impact that it produces on the life and the survival of the patient and the complication the patient lands on. Is there anything that we can do for diabetic neuropathy, or just we diagnose and commiserate with its patients? No, because the pathogenesis involves many components. There is, of course, hyperglycemia, which produces the inflammatory signals which can bring about the neuropathic damage. But what is not emphasized is the presence of dyslipidemia as well, increased triglycerides. In fact, there are many elderly patients who do not have diabetes, but if you look at the lipid profile, if they have high triglycerides, invariably they will be having neuropathy. Remember, triglycerides contributes immensely to neuropathy. Besides that, we have a lot of inflammation or inflammatory markers. This is a Korean study which looked at 513 patients of diabetes, and they looked at the components which induce the neuropathy in these patients, the chemokines, MCP3, the CD40, and so on and so forth. So there is an inflammatory player as well, which contributes to neuropathy besides dyslipidemia and of course hypoglycemia. There's a translational failure after failure in the trials. If you look at the trials up to 2008, the phase 3 trials were only 138, out of which the painful diabetic neuropathy trials are 126, and FDA approved only 3. And a disease-modifying therapy of the 12 trial, FDA has not approved a single one. This is Riaz Malik, who talks about the problems of the evaluation of patients of neuropathy, even in terms of trial. And this is the crossing valley of death, because many of those patients who have neuropathy do not reach the clinical evaluation, and therefore they die crossing the valley of death. And that's how the problems of neuropathy remains unanswered, untreated, unmanaged, unheeded. So the diagnosis of neuropathy, the approach should be to reduce the pain after underlying the condition and symptomatic treatment, improve the physical functioning, reduce psychological distress, improve the overall quality of life, and prevention if possible. So this is what we should approach the patients of neuropathy. If you look at the risk factors of the neuropathy, this is the TESFIAS trial published in NEGM, which looks at hypertension is 57% more responsible for neuropathy, which has not been looked in. Smoking, 38%, A1C, of course, 48%. And the duration of diabetes is also important. BMI, as I mentioned earlier, triglycerides and lipids also contribute significantly for neuropathy in patients of diabetes. Now, if you look at the evidence of treating neuropathy in type 1 diabetes, there is a good evidence in 1,228 patients that if you treat the glycemia well, they have a good response to therapy. And you can see the p-value is highly significant. But look at type 2 diabetic, on the other hand, looking at more than 6,000 patients, you can see here the treatment of hyperglycemia is not very rewarding in type 2 diabetes. It's very strange to realize that type 1 diabetes behaves differently in type 2. Maybe the methodology by which the assessment of neuropathy was done is different. Here they use the EMG NCV, but here you use just clinical examination of a knee jerk and ankle jerk to evaluate the patients of neuropathy. Maybe that is the cause why the difference in neuropathy. But this is the combination therapy, which was done by Muhammad Abdul Ghani, and who looked at the combination therapy in patients with type 2 diabetes, where they use exenatide and pioglitazone, which Dr. Tevaskar spoke excellently about the molecule. And of course, the basal bolus insulin poorly controlled patients of diabetes. Definitely look at the scores. The DNA4 score show improvement. The pseudoscan shows improvement. And also you can see the improvement in these patients. So again, proves the point that the initial presentation, which I mentioned to you earlier, probably the evaluation was not done correctly. So therefore, the glycemia control is important and does play a vital role in patients of diabetes. This is a very interesting study which looks at the outcome of the field study, fenofibrate, and very interestingly, it looks at the important improvement in the neuropathy by using the fenofibrate study, which is again very important and very interesting to know that the triglyceride reduction also plays a very important role in therapy of neuropathy. The bariatric surgery done in some patients also showed improvement in neuropathy, and that is evaluated by corneal confocal microscopy. And these are the pictures of corneal confocal microscopy. You can see the nerve endings are almost broken. They're not seen steadily. You can see again here. And here you can see the nerve endings have recovered very well. So corneal confocal microscopic evaluation of neuropathy is a very good way of evaluating the patient. Of course, it will be expensive and not easily available in this country at the present point of time. So the neuropathy improvement, neuropathic cause, as per the ADA position statement, is common in about 21% of patients are diabetics. It's much more common in women and especially common in the South Asian origin. So South Asian origins have a high incidence of neuropathy. And the cause of painful neuropathy is, what's important is the ascending tracts, which are the spinothalamic tracts, which go along the lateral margin of the spinal cord, and they go up and reach the thalamus, and from thalamus they reach the parietal lobe. And so that's the tracking, which is very important. But what is not emphasized is the descending tract of hypoalgesia, which is very important. Just to give an example, if you touch a very hot utensil without knowing, suddenly you take the finger off and start shaking that finger. And what is that in effect? That effect is the descending tract of the hypoalgesia, which is the inbuilt mechanism which is supposed to take care of the pain. In diabetic patients, when they have neuropathy, not only the exaggeration of the ascending fibers taking the impulse to the brain, but the decrease in the descending fibers taking the impulse downwards as the analgesic fibers, which is very important also to understand when you discuss the management of diabetic peripheral neuropathy. So therefore, when you use the mechanism-based treatment for neuropathy, of course, we have the drugs which use the peripheral sensitization, where you can use a capsaicin or lignocaine, which is there, which can improve the nerve lesion to some extent. When you talk of the effect in the ascending fibers, we have a medication which work both at the central and in the periphery. We have the central and peripheral drugs, which are the calcium channel blockers, which are alpha to gamma delta ligands. They are the tricyclic antidepressants. We have a painkiller like tramadol or tapentadol, or the opioids, which can be used as the infection treatment in treating the acute severe pain which the patient can bear many times. This is the American Diabetic Association Diabetic Peripheral Neuropathy consensus statement. First of all, you have to find out is the pain due to peripheral neuropathy is confirmed. So assess the comorbidities, potential for the adverse drug events, interaction, cost of selection of therapy, any of these three choices that you have. So first you have, of course, we have a voltage gated alpha 2 delta ligand pregabalin or gabapentin. Then we have serotonin norepinephrine reuptake inhibitor, which is duloxetine, which is basically antidepressant, which was first approved by the US FDA to treat patients of neuropathy. And 6 months later, the pregabalin drug was approved in 2004. And then we have a tricyclic antidepressant, which either is nortriptyline or desperamine. So there's no meaningful or clinical benefit when you give these kind drugs. Then switch to another agent. That one we can do. You can do combination therapy. You can combine pregabalin with the serotonin norepinephrine reuptake inhibitor, or you can combine all three like tricyclic antidepressant and duloxetine and pregabalin. And you can add tapentadol or tramadol if you have to break the response to the pain the patient can't bear. So therefore, if they're still not well tolerated, then you send to a special pain clinic in various hospitals. So these are the drugs which are available to us, the peripherally acting drugs, the capsaicin or lidocaine patch, the carbamazepine. It is specifically reserved for post-trigeminal neuralgia, herpes, neuralgia, followed by herpes infection, or gabapentin, again, post-herpetic neuralgia. Pregabalin can be used for fibromyalgia, peripheral diabetic neuropathy, post-herpetic neuralgia, and a spinal cord injury. And of course, we have SNRI, which duloxetine and milpiciran. Both these drugs can be used to treat for patients of fibromyalgia and diabetic peripheral neuropathy. The pregabalin works differently than other antidepressant opioids because definitely has action. It dampens the ascending pathway and improves the descending pathway. It's very important that the pain stimulus is also reduced and the pain perception at the center is also decreased. So pregabalin works differently. It blocks the opioid and other centers in the brain to block the pain perception. It reduces the ascending pain through the spinothalamic tract and therefore relieves the pain and improves the descending pathway and therefore reduces the pain stimulus. So therefore it has the action at all the three sites, and that's the reason why pregabalin is indicated to treat patients with diabetic neuropathy. In the clinical trials, you can see pregabalin is definitely better compared to the other placebo, where the relief of the pain is 40% less compared to the placebo trial. But the truth about the management of diabetic peripheral neuropathy is only 30 to 50% of the patient respond to therapy. And that's because we have to understand why drug fails. And this is the pharmacogenomics, where all people are not the same. So one size doesn't fit all. So there are people who have a full response, there's some partial response, they have non-responsive, and they have severe adverse reaction based on their pharmacogenomic setup. And therefore, it is important to have a personalized medicine even to treat patients of neuropathy. And this is one study which looked at oxcarbazepine to treat patients of peripheral neuropathy. And here, if you decide which patient would respond to therapy, and that is defined by the Z-score, and you can see the pain increment, or what is called as the painful symptoms the patient has, allodynia especially, and those are the patients who would respond extremely well, where the number of needed to treat is just 3.9. Those who do not have that kind of symptoms of allodynia, the QST, on the QST parameters, you can see here, there the response is not poor. So sometimes we have to decide or find out which patient will respond to which drug, which of course is a part of personalized medicine, but is also important in patients of treating neuropathy. So therefore, what I mentioned to you earlier is not only important to treat the ascending pathways by using the SNRIs and of course the pregabalin, and also descending pathways, which are very important analgesic pathway, which are also treated by 5-hydroxytryptamine, norepinephrine, and also the pregabalin. So therefore, the vitamin D is also very important. There are studies which looked at vitamin D and the painful diabetic neuropathy. This is again a study which says that when you give vitamin D supplementation to patients of diabetic neuropathy, they respond extremely well. So that's again is those patients who have a vitamin D deficiency. This is a study done by Selvaraj. It also says that the calcium influx into the neural cell is better under influence of vitamin D, because the calcium influx is very important for the neuronal conduction, and that is improved with vitamin D. So therefore, in patients of painful diabetic neuropathy, you can use even the vitamin D. So therefore, the differential types of pain, the C fiber pain is classically what is called as the burning pain, dysesthesia, allodynia. And here you have a drug like clonidine, which works very well, or a non-sympathetic drug like capsaicin, lidocaine, mexicillin, which is the analog of lidocaine, also work well. The alpha 2 delta fiber pain, which is a deep-seated gnawing pain, toothache-like pain, there are benign drugs you can also use. You can use insulin infusion in these patients. Again, clonidine works, lidocaine, mexicillin, carbamazepine, calcitonin is known to work. And of course, we have a host of the drugs which work on the both pathways, the C fibers and alpha 2 delta pathway, which are antidepressant, phenothiazines, amitriptyline, and of course, anti-epileptics, gabapentin, NMD antagonist, and of course, tramadol. So therefore, the diabetic neuropathy, the American family physician has said that first confirm the diagnosis, improve the metabolic control, look at the patient who has an insidious onset, the sleep is normal, then you use gabapentin, capsaicin, or if no relief, then go on to pregabalin, GTN spray, and lidocaine patch. If the patient's sleep is disturbed, then use tricyclic antidepressant. You can go maximum up to 100 milligram, but be careful about his anticholinergic properties, especially bradycardia, retention of the urine. All that's important to keep in mind. Then, of course, then you can add gabapentin. If there's no relief, then you can again keep on adding the drug like pregabalin, GTN spray, and of course the tramadol for the breakthrough pain. And if the patient has acute onset, then of course the gabapentin 300 milligram twice a day, and you can also add amitriptyline into that with 600 milligrams. You can, if the patient has a poor sleep, then you add tricyclic antidepressants, try again pregabalin and GTN spray and tramadol for the breakthrough pain. But remember that its first important duty is to improve the metabolic control. And most patients who have an upset of the metabolic control can present with acute onset pain, which comes as allodynia, which is very important to remember. And the patient still is unhappy, you can refer to the pain clinic or refer for admission. See that the emerging treatments for neuropathic pain like botulinum toxins, lidocaine, high concentrated capsaicin patch, then locasamide, which is again a drug which is used to treat the convulsion disorder. Alpha agonists have been tried, NMD receptor agonists are the new kids on the block. The neuroregenerative agents and of course the combo therapy are all many of these drugs which can be offered to these patients to have treatment. So just to summarize what I said in last 15-20 minutes, that chronic neuropathic pain is a disease and not a symptom. Significant impact on patients' quality of life, sleep, and work productivity is important due to neuropathic pain. And therefore, the treatment goals should include the balancing efficacy, safety, and tolerability of a drug, reducing the baseline pain and pain exacerbation, improving the function and the quality of life, and new agents, new users for the existing agents offer additional treatment options. So at that word, I think I thank you very much for the patient listening.
Amazing, sir, and especially when it has been delivered at such a last extempore and last moment talk, it is worth a million appreciations.
Thank you.
It's such a difficult topic that you have handled so beautifully well. Sir, if you permit me, can I have a couple of questions for you?
Sure.
Number one is, is the approach should stay same as far as evaluation? I'll talk about evaluation of these patients, whether you are suspecting a small fiber neuropathy or a large fiber neuropathy, or to some extent diabetic amyotrophy, or if you talk about even mononeuritis multiplex or entrapment neuropathies, which can be possibly there. Do you have the same kind of approach as far as the pharmacotherapy is concerned, or we need to individualize?
Yeah, you're right. In cases of entrapment neuropathy, of course, the treatment is to release the entrapment. That is the basic treatment. They require a small dose of steroids or the splinting of those arms, and maybe surgical recorrection if that is needed, because the patient doesn't respond to them. That is the only option. But the other neuropathies are basically as a vasculopathy, because it's basically a microvascular disease. And therefore, it is the involvement of vasa nervorum, which on occlusion produces infarction, whether it's a femoral
Absolutely.
nerve, whether it's a peripheral nerve, whether it's a sural nerve. So ultimately, it's a vaso-occlusive disorder because of the hyperglycemia, which is responsible for these disorders. The classification is very arbitrary. When we say it's a C fiber and a large fiber classification, very arbitrary. But it's important to distinguish this because the management may change slightly. For example, if the patient has the crowding of his toes, or the patient has a hammer toe, and the patient, when he walks in a room, he cannot walk in a straight line. These are the patients of a large fiber neuropathy, which requires an urgent and a good diabetes control, because that can regain the patient's confidence. On the contrary, the small fiber neuropathy can go on for many years. In fact, they are not responding to treatment, but there the controlling glycemia is only an option. And other therapy, which I mentioned, either the duloxetine or pregabalin, is only for the symptomatic relief. But ultimately, it's a time which takes, and quite often, as I mentioned to you earlier, 30 to 40% patients only respond to your therapy, which is very, very distressing symptom. Most of the patients don't like it. Many patients don't like the breeze of the fan on the feet. They can't take the bed sheet on their feet. That's why it's quite
It's very
distressing.
difficult. It's very
This,
difficult.
then of course, the glycemic control and using these drugs and eventually tramadol are some of these drugs which can be used to allay the anxiety and the pain of the patient.
So can we say that, sir, that rather than allowing these patients to develop neuropathy, if at all you probably intervene or diagnose it or suspect it early, and
Yes.
probably try and intervene it early, the
Yes.
beneficial effects would be much more than probably
Yes,
the
even
moment
much,
you.
yeah, even much before diagnosis of diabetes, Mangesh, even patients of impaired glucose tolerance and patients with impaired fasting glucose can have neuropathy, which can remain silent for quite some time. Because if there is a nonsense or insensate food or nonsense food, many of the patients don't realize it unless they start getting injury, they get infection, and then they come to you. By the time a lot of time has passed away and a lot of problems have already occurred, and most of these patients are the patients who land up for the amputation.
Yeah.
So
The other
may I?
question,
Okay.
Yeah, yeah, yeah.
Arsenal,
I
go ahead,
just
go ahead.
wanted to ask something very simple, that is there a difference between what agent we use to control hyperglycemia? I mean, between the OHAs, insulin, between the OHAs, some people often stay, although I don't know if studies validated, but using insulin worsens the situation, even the control gets better. Is there any study
Yeah,
for
I
it?
think there's a mixed answer for this. The first is in the acute neuropathy because of the uncontrolled diabetes. There's evidence to say that if you give them insulin infusion, these patients improve because the neuropathy is induced by the acute glycemic disturbance. And it's interesting to say that as the glucose level rises, the first place where it runs very easily is the nerves, because there is no insulin resistance. So nerves are the ones where the glucose finds easy way out. And therefore, if we can quickly control that glycemia in an acute setting, maybe the insulin infusion is useful. There's also use of C-peptide in these patients on the similar principle where they show improvement in neuropathy. In the chronic setting, as you said earlier, when you suddenly control your diabetes, there is some risk which increase. One of them is neuropathy and secondary retinopathy. Even when we looked at SUSTAIN 6 trial, when there was an increased retinopathy by 60%, people felt that you suddenly control these patients' diabetes of a long duration, there these complications can come in. So therefore, in situation like this, where there's a chronic dysglycemia or a hyperglycemia, and there you suddenly bring insulin or get your sugar down with even by oral medication, there's a possibility that these neuropathy can become worse. So initially in the past, it's also called an insulin neuritis. This was how it was called in the past. Of course, it's a misnomer because the neuropathy is induced by sudden control of hyperglycemia. So in that case, it's bad. And any drug you can use to control hyperglycemia, because it's chronic neuropathy is actually a very chronic disease. It's not a symptom, it's a chronic disease. And there you have to control glycemia well, but the benefit of control of glycemia is not very great. That is a bad part of the story. Only in acute, like I had a patient who had a fight with the husband and she didn't take one-day tablet, and next day she came to with severe allodynia. And I asked her one simple question: what happened to you? She said, we had a lot of argument in the house, so I didn't take the medication, so my sugar went up. And that patient, when I gave a short insulin therapy, she improved very well. And Mangesh talked about patient who having the femoral nerve injury, a femoral nerve infarction, as it's called in the past was amyotrophy, but it's actually not amyotrophy, it's a misnomer. It's actually neuropathic disease, but not a muscle disease.
Muscle disease, yes.
Those are the patients who have a lot of systemic symptoms. They come with fever, they come with headache, body pain, and they have severe weight loss. These are the patients which might benefit with a good insulin therapy. And the duration for a cure for these patients can be as long as 1 year. You need to treat them very carefully and meticulously for 1 year time to have a good results in these patients.
Fantastic. So
I've
I think,
answered your
friends,
question.
that was one of the fantastic sessions that we had. I'll just end up with one fun fact to say that, nerves are really important. They need your attention. If you really align all your nerves from head, and if you keep your nerves, each nerve in line, you will travel from Mumbai to Bangalore easily. So you need to understand that much is the coverage.
Mumbai
So
to
that much is
Aurangabad.
the part to be taken care of. Thank you very much, sir. And
Thank you,
over
sir.
to
And thank
Thank
you,
you.
Dr. Mangesh.
Thank you, Mangesh, for staying back.
No,
Thank you
no
very
country,
much.
sir. It's always a privilege to listen to you, and it was such a wonderful learning for me. And I am so mesmerized that you could deliver absolutely
I know,
last
on the
minute
spot,
extempore
yes.
talk. Too good. It was.
Thank you very much for appreciation, both Mangesh and Saida,
Always a
madam.
pleasure to learn.
Thank you, madam.
Thank you.
Thank you.
Thank you, sir.
Bye.
Thank you, Dr. Mangesh. Thank you for holding the fort. Thank you.
No
Thank you.
question.